Hello to everyone. Good morning. I'm here again with a small daily dose of anatomy. So today's topic would be the superior orbital fissure. So superior orbital fissure, I'm going to explain you briefly with the help of a diagram. So diagram I've picked from theme dissector. So it has a beautiful diagram, and I'm also going to give you a little bit information on the clinical anatomy as well. And many of you may not be aware that superior orbital fissure is on a different bone and inferior is on a different bone. It is not the continuation. So such information you may miss out when you mention. So which is very important, and these things that add to little more elaborate explanation in your answer scripts. So I hope everyone is studying well, and I hope my series will keep you motivated to do better. So keep watching my videos on the YouTube channel, and please do subscribe and like and do comment. And if you are interested in any particular topic, do comment so that I can make more videos. And this is my hobby, and I love to do it for you. Thank you. So here we go. This picture shows you the superior orbital fissure. So the superior orbital fissure is a gap that is present between the greater and the lesser wing of the sphenoid. So here you can see in this picture there is only superior orbital fissure. So this entire thing is superior orbital fissure. Whereas the inferior orbital fissure, it lies between the posterior wall of the maxilla and the greater wing of the sphenoid. So those two are two different fissures. Okay, that you should remember. Now the superior orbital fissure is divided into three parts. So you can see the upper part, which is upper lateral part. There is the middle part and the lower medial part. So this is lateral, this is medial, this is the middle part. So here you should remember, since this is the middle part, this tendinous ring is present medially. So this is towards the nose, and this fissure belongs to the right side. This is the right superior orbital fissure. This is the right orbit. Okay, this diagram is of right orbit. So what are the structures that is passing through the fissure? Let's see. So you can see there are many structures. One is here. You can see the recurrent branch of lacrimal artery, lacrimal nerve, frontal and trochlear. You can remember this as LFT, left. Okay, you can remember this. And then this one, superior ophthalmic vein. Immediately when you put this in the diagram, you can also include the inferior ophthalmic vein, which is the only content in the lower medial part. There are four structures that are present in the middle part. So here you can see upper and lower divisions. There are two divisions of the oculomotor nerve. There is one nasociliary and abducent nerve. So all the four are nerves. And green thing that you can see here is the tendinous ring. So tendinous ring you can see here. And the tendinous ring includes all those four recti muscles. So since this is medially present, you know this is the medial rectus. The other side is the lateral rectus. Above will be the superior. Below will be the inferior rectus. So above this will be the smooth muscle. So that is that also includes the smooth muscle component, that is Muller's muscle. So some of the fibers of levator palpebrae superioris also includes the Muller's muscle. So you should remember that this is involved in slight partial drooping of the upper eyelid, which is also known as ptosis. Okay, so that is one of the clinical anatomy that you can remember. All these recti muscles are supplied by the oculomotor nerve. So nerve supply, you can remember it as S44 LR6. So you can remember S44 LR6 3. What is S44? That is superior oblique is supplied by trochlear. LR6 lateral rectus is supplied by abducent, and 3 is rest of the muscles are supplied by oculomotor. So whenever there is a lesion of the oculomotor nerve, you should remember it produces paralysis of the muscles of the upper eyelid, which it supplies, and results in ptosis due to the paralysis of the upper eyelid. So that means, what does that mean? It means the eyelid cannot be elevated. Then another one is if there is any squint, you can call it as lateral squint. That could be due to unopposed action of this lateral rectus muscle. So here this is seen in almost complete ophthalmoplegia, you can see. So that is unopposed action of the lateral rectus results in lateral squint. There is one more thing that you can remember, that is dilation of the pupil and loss of accommodation reflex. So this also could be one of the clinical anatomy. So now here you can see all the recti muscles are present here on the tendinous ring. So there is the 4 recti muscles. So this is levator palpebrae superioris. Due to paralysis of Muller's muscle, which is again a smooth muscle component of LPS, that is this muscle, results in partial drooping of the eyelid. So if the sympathetic innervation of the eyeball is involved, then it will cause one more condition, that is called the Horner's syndrome. Horner's syndrome, it is characterized by again drooping of the eyelid. Then there could be constriction of the pupil, which is called miosis, that is due to unopposed action of parasympathetic supply. Then there is dry phase, that is called anhidrosis. Flushed phase, that is due to vasoconstriction. Ophthalmos, that is sunken eyeball. So these are some of the clinical anatomy that you can mention. So this is how you remember. So you can see the small optic canal here that is present within the tendinous ring. There are 2 structures within the optic canal. One is optic nerve and ophthalmic artery. So these are the structures that are present within the tendinous ring, and you can also see the subdivisions of the superior orbital fissure. So there are 3 parts: upper lateral, middle part and the lower medial part. So it is as simple as this. So it's very easy also to remember. Don't forget to draw this diagram.